It's a huge honor to be here again this year, so thank you all. And if you're new and we haven't met, like Lacey said, we're sisters. My name's Kat Greiter, and I have been with digital marketing agencies for most of my career, spent some time at the Gates Foundation, and global health has been a topic that I've nerded out on for a long time, and so it's exciting again to be in this room for me. So we are going to shift. I get the joy of reflecting a little bit on all of the good work that we did last year. Again, I say we broadly, many of you were here, and if you weren't, again, now you get to take credit for all of that, so you should. And then what we're going to do is we're going to start by looking back, and you just tell me, Ashley, when I have a, no worries. We're going to start by looking back at the MVP outputs from last year, and we're going to reflect on that. We'll do a little bit of like kind of asynchronous, little quiet thinking for you to just read it because it's a text-heavy slide. And then we're going to assess that through what's called the purpose to practice methodology. It comes out of Liberating Structures, which is this kind of set of tools that is approved through some of the dissemination and implementation kind of guidance or curriculum. So we'll look at that, and MVP comes from the Agile world, and so we want to butt it up against or kind of reflect on it through this purpose to practice methodology, just to make sure we haven't missed anything, gives us another way to assess it. So thank you. Perfect timing. Okay, thank you. So 25 minutes, we'll do reflect on the MVP. Then exciting things have happened. And so we're going to spend then about 80 minutes. You're going to get up and we're going to walk around. And the team from TechToom has put together a really awesome app based on what we said we wanted to accomplish last year. So we're going to capture user feedback on that in kind of an interactive session. So you'll break up and move around. And you'll see the majority of our time kind of with me at the podium will be spent on that. And then we'll move into the second output from last year's MVP. Lacey will guide us through that. It'll be a panel discussion. And then we'll prepare for how we'll spend the bulk of our time together in the kind of stratified or adaptive guidance, how we're going to achieve that, because that was, again, one of the things last year we identified that we wanted to solve for. So just at the top, again, reminder, MVP comes from the Agile world. Purpose to practice comes from again, kind of the D&I playbook. And so we're looking at these two things together to build consensus, but also, I would say, deliver solutions at pace. So, Ryan, Ashley, doesn't want to go. Just use this. Okay, and I just hit the arrow on there. Well, the suspense is going to be worth it, I can tell you. Oh, God. Can I just do this? There we go. No worries, all good. Okay, so I'm going to give you a handout, and or you can read it up here. And so, again, it's just a chance you're going to take just a couple minutes and reflect on the output from last year. And then at the same time, because I'll give you both of these, we're going to kind of just take in this methodology from purpose to practice, which, again, you know, what I love is that when you kind of look at the history of some of this purpose to practice is they'll say they had a hunch that frontline workers could really help solve a lot of the problems that were being faced in healthcare, and that they wanted to find a way to kind of unleash that creative problem solving. They also had another hunch that they could mobilize large groups of people to actually solve these problems, and that it wouldn't just lead to total chaos. And then, you know, when you think about MVP, it's very focused on the end user and how do we iteratively solve for their needs. So again, nice alignment there, but I want you all just to get a chance to kind of absorb how these two structures work. And then the other thing to note about MVP and this purpose to practice as a shared space is that as you move through the places on the wheel here, one should inform the other. And same with MVP, we have, right, objectives, audiences, risks, KPIs. They should all work together. Like you should be able to look at one and then go gut check. You know, when you look at the KPIs and you gut check it against the objectives, do they make sense together? So we'll do that. I will give you those handouts. And then we're going to go through the purpose to practice where we've married the MVP to the purpose to practice one by one. We'll do it kind of rapidly. And then you're going to get a few minutes to take a survey, because what kind of conference would it be if you didn't get to, like, vote on things? And in essence, to tell us what we might be missing from the MVP as you reflect on it through this new lens. So I know there's kind of a couple steps in there, and that's just our first 25 minutes. So I'm going to see if some folks will help me hand out the printouts. You're going to read it, and then we'll go through these. We'll give you about like 3 to 4 minutes to do that, and then we're going to go through those purpose to practice reviews one by one. Awesome. Oh, look at that. Thank you. So I'm going to advance the slide. Nice. Thank you. Lacey pointed out that it might be helpful as you're thinking about looking at the MVP and this purpose to practice structure is just a reminder, a level set of kind of like our big why we're all pulled together. And so here is the way we took the output from last year's MVP and framed it as a purpose. So relieve human suffering by improving trauma clinical guidelines, design and implementation, or trauma clinical guidance, design and implementation. So I'm going to let you read that. And again, as you reflect on the MVP and the way purpose to practice works, just know this is why we're kind of all in the room together. Set a timer. See who reads fast. Okay, just about half a minute. Let me know if you need more time. Okay. So I'm going to take us back here for just 1 second before we go through those slide by slide. If you look at those top 3 objectives from last year, so again, if you weren't in the room, it was a process with a lot of sticky notes, and everyone had to take on kind of, they had to embody different types of users. I think I was in the group with the ER docs, and we all had to do our best impersonation of being an ER doctor and look at the world through their lens. So that happened in a number of different groups. We did stickies, and we came up with these objectives. Those top 3, so again, like I said, in the next part of the morning, we're going to go through the progress that we've made on number 1 and number 2. And you can see just from the amount of text by number 3, it's a meaty one, but that's what we're going to spend a lot of today and tomorrow working on. Okay, we kind of already paused on this one. When you take the survey, the question is going to be, as you consider that prompt above, so why is the work important to you in the larger community? Are we missing anything in that statement? It's okay if we are. Like, this is the point, is then we get smarter, hopefully a year passes and we learn some new things and we get a little smarter, and so we may want to refine or add some things. In terms of principles, the question through the purpose to practice lens is, what rules must we absolutely obey to succeed in achieving our purpose? In essence, what must we do or what must we not do? And we said, and you'll see again when if you're looking at that MVP printout, there's a little bit of, we didn't write those We didn't write principles in the MVP because it's meant to do a different thing, but when we look at it through this lens, we agreed on being collaborative, so working together generously and transparently on shared goals and outputs, being inclusive, so that was all trauma care providers and patients are part of the design and implementation process. We wanted diverse practice types, community identification, geographic locations, and then accessible and useful, so free, timely, current, and in a format that is easy for a practitioner to use at the bedside. Participants, we talked about audiences last year or users. When we think about participants who are involved, the question from the Purpose to Practice framework says, who can contribute to achieving our purpose and must be included? Again, a little bit of a nuance because in the Agile world, we're thinking about who's the user, what are their needs, and here we're thinking about who can contribute to achieving our purpose and must be included. See at the bottom, diversity of participants is critical to success. We will actively include participants of, again, the practice types, community identification, and geographic location that we listed in the previous slide. So again, these things have to all fit together. Ooh, what is happening here? It's blocked out. We didn't talk about structure at all last year because that's not really part of how MVP works. So tomorrow we're going to have a session on structure. And the question is kind of like, how must we organize ourselves in order to achieve this? So we've got a breakout tomorrow on that. You won't need to reflect on that one. And then practices, which is, again, the way that Purpose to Practice talks about it is what are we going to do? What will we offer to our users and how will we do it? When we do the MVP, we make ourselves kind of get to the same point, but we have to prioritize it. So here is just kind of a shortened view of that previous slide that has those objectives outlined in priority order. Okay, so here, if you will, you can open the survey. And you'll see, if you say yes to something, like something's missing, then you have to tell us what it is. So you'll see a form field after that. We can type in some text. And it's just the 4 questions. If you need any help navigating the survey, raise a hand. And then tomorrow we'll share out key themes from the survey. So I'll give everybody about 2 minutes. You've got those printouts you can use to kind of reflect. And if you're if you're remote, I think we're going to try to drop in those MVP overview and the P2P framework so that you've got those for reference. But I can also skip around in the slides, so don't be shy. Anybody still need the QR code? All right, I'm going to flip back again to this one as it's a good grounding. Thirty seconds left. See some heads down. It could be the survey. It could be Instagram. I don't know. The survey, okay. Maybe a little more time. All right, how you doing? Anybody need more time? It's okay if you do. Yes, okay. Do one more minute. We have our remote group, just another minute as well, because I think they just got those images, and then we'll have a quick discussion. Okay. How we doing? All right, I got a thumbs up. Awesome. We will, like I said, at the end of the day tomorrow, kind of share out what we saw from the responses. But is there anything that anybody, as you were reflecting on this, again, through this slightly different lens from last year, or just revisiting those outputs from last year, anything that came to mind that you want to share or ask the group? We've got a few minutes.
Did I just turn it off? Oh, no, you can hear me now. I think a lot has gone on in like informatics and guidelines in the last year. And I worry when I look at this, like, I'm not sure this is really like the MVP. And I worry that like if we just build an app that has all the guidelines, that's not going to move the needle, especially outside of the level 1 trauma centers where I really worry, like, what will be the uptake? Like, when I think about an MVP, I think that an MVP should really be like a multi-platform app that integrates with the EHR, where I can look at it and it can tell me for this patient, what should I do next? That might sound like futuristic, but like there's already a pilot undergoing that's doing that with the Brain Trauma Foundation and VTE prophylaxis that has been scaled across multiple trauma systems in the country. So I would say an MVP is like pick 2 or 3 guidelines and, you know, build the full system, and then scale it across. Can we do it across 10 trauma systems and then kind of keep going? In collaboration with like BTF, Chest Well Injury Society, et cetera, and have those American College of Surgeons, COT, and have those societies own kind of the evidence synthesis part. I don't know, just my thought.
Because we're gonna have a presentation this afternoon that's mostly about what Chris is talking about, and that, like, the widgets exist, but the widgets don't fit together and they haven't scaled yet. So, like, for what you're just describing now, the two main opportunities I see is interoperability, right? Of, like, we know every Epic system, et cetera, is a bespoke system. So as you scale, it's like writing new code for each one. And then two, like, the work you're doing, you are very well funded. And so if we think about the financial barriers, what are your thoughts on those two opportunities?
I think this is something the American College of Surgeons should fund. You know, they have a large endowment, and I think that this would be a good use of that endowment, to support this. Like, it does cost about $500,000 to develop this system. But, you know, we were able to deploy this across Epic systems and Cerner systems. So Indiana University is one of the sites, and they are on Cerner. So I know that this is doable, and but I know that there's been heavy talk and a lot of push to build an app that just has all the guidelines on. But think about, like, also at the point of care, like, people are going to pull this thing up and then try to find where their patient is at. I don't know. I really think this is an important discussion around, like, what is the actual, and then, yeah, who's going to pay for it? I think that's where the college steps in.
I think two questions back this way.
I'm not going to speak for the college, but I do think that we need to think differently than we have in the past. I don't think that this should solely live within our professional organizations, because we're relying mostly on volunteer time. We're relying mostly on busy surgeons and clinicians and emergency physicians taking time to build these things, and then we build them, and then they're outdated a year later. So I think we need to think differently, and that's where I think your concepts, and I know nothing about AI, like, it's a black box to me, but I think your concepts around how do we build a system that allows us to leverage the wisdom of the experts, doesn't rely on the experts to do all the work. Because I don't think we can otherwise keep something current. I don't think we can incorporate the new evidence rapidly. We've proven we can't. 17 years or something, judge the quality of that evidence to decide if it should be incorporated or not, to make a change. You know, people will do a study and they think this is the best thing since sliced bread, but there's a lot of limitations to that particular study, right? So is that enough to change the guidance? So I think there's a lot of, I'd like to think outside the box a little bit today about not relying solely on the professional organization. Obviously, professional organizations have to work together, and there has to be consensus, and there has to be collaboration, and there has to be, you know, all the experts working together, team science, to make this work. But the infrastructure, how we deploy it, how we make it work, can't rely on the professional organizations or the volunteer surgeons alone to make a successful long-term. And that's what I added in the survey on number 3. We say the word current on number 2, but on number 3, we don't really have a bullet on how we would actually, what is current, how we would actually do that. And then I totally agree with Chris that integration into the EHR is also, I think, really important from the side, because that's how, if it doesn't pop up on the screen when you're caring for the patient, it's probably not going to be.
Mitch Cohn from Colorado. I agree with everything that was said. I think just putting a place where a one-stop shop where you can find the guidelines is great, and it's better than not having that. But I think the on-the-ground understanding, this applies to my patient, this applies where my patient is in their physiology, biology, injury right now, is really relevant. I understand that's expensive and hard to do. I'm going to talk a little bit this afternoon that it's already done and can be pushed forward. Maybe the college's bully pulpit and money is better spent not in developing it themselves, but actually saying this needs to be integrated into the already existing EMRs, because even the smallest places are probably on one of the 2 big platforms, or maybe a handful of platforms. Maybe the college's, you know, pounding fist can be Epic, Cerner, whomever else. These are our guidelines, and they need to be applied in the EMR, which gets it pushed forward and makes it understand where how it applies to your particular patient. The other thing that I think is really important and I think is missing, if you have a one-stop shop, let's just fiat, okay, it's 3 a.m, you can say, okay, here's my patient, I can bring up the guideline really quickly. How do I know that that guideline's correct, that it applies in this particular clinical circumstance, that there's not competing guidelines out there? It's remarkably unsexy heavy lifting to do, but I think important for this group to do, not just have a place to get it, but to actually have somebody be able to trust that it's been vetted, it matters, it's a source of truth, especially in the age of AI where, crap in, crap out. I think we need to be the supervision of that. And if somebody can trust, okay, I'm on that app not just because it's the one place to find it, but it's because the group that I trust said this is right, or as right as we can be with current science and updated guidelines and all that stuff, I think that's hugely important. We should not overlook.
We have time for maybe one more, and then we will certainly spend more time tomorrow. Can I say 2 more? I'm looking at my timekeepers. So many hands raised. I know, I think I have 3 more minutes in my section, right? Is that right? She's nodding. Okay, we can take as many questions as we can do. 3 minutes or comments. Yes.
Janet Becker from University of North Carolina. These are excellent comments, and maybe guidelines where is the adoption in between. We're talking about some of these things, EPIC and et cetera, and what we don't often do with clinical guidelines is have the second paper that should come after that, which is how do you implement them, which is why we don't operationalize them, don't have systematic adoption, and we have a lot of provider variation. So even for the app, still choose to implement them in that. And so there's this hovering piece of it does take a long time to update guidelines and evaluate evidence for where we are, but we also have a whole consensus operation that needs to implement these. That's when we start to actually vet how do we use these, which cases do these not apply to systems. We'll not be able to apply these if you don't have these resources, if you don't have these. There's an adoption level that needs to happen between guidelines and a whole compendium of documents we probably need to consider in between a discussion of guidelines and however they're going to be, and what do we do with them.
Yeah. Okay, oh, God, just right under the wire. Thank you, keeping me honest. I love this, and I know there were other hands raised, so apologies, but I think this is, again, what you all are, the threads we're pulling on are definitely part of what the conversation bulk of tomorrow will be spent on, and I'm sure today will continue. So I'm going to go ahead, though, and move us on. So our next section is to, in essence, review, like you all said, kind of, it's better than nothing. It is good to have our guidance and guidelines in a single place that's easy to find. And so that is the kind of step one. And again, I think what's good about the MVP objectives is when we prioritize, part of that prioritization process is through the lens of what helps us hit our minimum kind of success and what is required to kind of be feasible and viable. So we're going to dig in there, and I'm going to flip us ahead. Or are we supposed to have a break now, Lizette? No, she's saying no. No, sorry, guys. So to that point, objective number 1 from last year, develop an accessible, free or offline, easy-to-use platform to house existing guidelines that is recommended to be used in every hospital, every time, every patient. We had a nice debate about every time, every patient, every hospital. I think the point was if the guidelines are the guidelines, then we do want people to feel like they are, they should be used. I'll leave that to the experts in the room, though, to decide if you want to continue to debate that later today. But guys, you were right. You should all feel so good. There was we could not have a conversation yesterday without someone being like, it's an app, right? It's an app. We need an app. And what we didn't want to do last year was jump right to the solution before we had clearly identified the problem and kind of what it is that we needed to solve for through that user lens. But it was an app that we started with. So in the last 6 months, the TechToom team, which is sitting back there, Mark and Neil, hello, have developed an app that houses 258 guidance and is searchable in several formats, working closely with Gabriella and some others to get that all pulled together and kind of curated. And going forward, this content would be updated with new clinical guidance identified via iterative systematic reviews. Lacey will talk in the next later about kind of how that content will be curated, how kind of the backlog or the pipeline of research that goes in to feed that will be orchestrated or better collaborated on. But we're starting with the app. And so in this next session, we're going to do these user experience reviews. And I'm going to see, do we have Len in, Ashley? Can you hear me, Len? Is Len dialed in, Ashley? I don't know if he can hear me. While we wait, I will give you a quick intro to who he is. So Lynn has a long background in user experience and accessibility. So he's part of several kind of international groups that help make sure that the internet is accessible for people, that the web works the way that it should for people of different abilities and in different contexts. And he and I have worked together for a long time. He's a very thoughtful person. I will tell you that as we were starting to have these conversations and he was reviewing some of the content and working with Neil and Mark, his brain was going to places where it's like, okay, so you're on a snowy slope and you've got your polarized sunglasses on and you're trying to read the app, because in his head he's a search and rescue or he's an EMT, and then he's also, okay, but now you're at the bedside, you don't want to use your hands, wouldn't it be great if it was voice control? So he was already very thoughtfully trying to think about what are the different user types and user needs. Obviously not all of that will be reflected today in the app that you explore, but just know you have some people thinking about it that are really trying to kind of push to the far ends of how users might actually really need this in real world scenarios, not in conference rooms. And so we're really grateful to have his time and expertise, and we've got 3 stations set up that you'll work through. You'll kind of move through and you'll engage with the app and provide us some real-time feedback through kind of a facilitated process. But I can't tell if we have, he's about to be. Oh gosh, again, the anticipation. So exciting. Lynn, just like yodel when you can hear us. Do something very UX-y. While we wait, I'll let him give his mise en place explanation, but just a little bit more detail is that you should have a full sheet that I think says what cohort you're in or what group you will be in as you move through the rooms. So take a look at that. And then it's the room 28 back there, and then the dining room, and then some of you will be staying in here, and we will move through it. If you'll have some grace for our facilitators, because we've been trying to figure out today how to get things pulled up on monitors at the same time as give you lots of physical stickies and notes to react to so that it can be a good interactive session. So when you move to the room, it may take just a minute for your facilitating team to kind of get everything ready for you. So again, if you will be gracious, that's appreciated.